Hey, good morning, everyone, and welcome to Euronurse. I'm your host, Vic Sinise. Glad to have you on board. If you're watching this live, you can be seeing us on YouTube, LinkedIn, Facebook. Be sure to like and subscribe. We're doing great on getting all those subscriptions built up, so glad to find out that you're watching us. If this is your first time checking out the program, be sure to check out our website at euronurse.com. Best place to learn more about the show. Also, the best place to go to watch all of our 145 episodes. Yep, 145. We've been doing this for a while, but there's everything that you could ever want to know about urology there. Now, some of you like to listen in your car. You got a long commute, want to have it pass by really fast. Go ahead and subscribe through any of our podcasting apps. They're all up there on the screen. So just pick any one. They'll come out about a half hour after the show goes live with the audio version. You can listen to us in your car. Hey, this is May, and May is Nurses Month. And then this is Nurses Week, I believe. So happy Nurses Month to all you nurses out there, myself included. So this week we had a great talk. We're going to be talking about recurrent UTIs, evidence-based strategies for diagnosis, regional trends, and optimized testing with Guidance UTI. We have our expert Margot Lee joining us. Margot, welcome to the show. I'm going to have you just give your own little introduction if you don't mind.
Thank you, Vic. Thanks so much for having me this morning. And I'm excited to be here on the Euronurse program. I was here last year and I talked a little bit to the audience about reoccurring UTIs and using the guidance test and talking a little bit about some of the details about this test. And today I thought I'd come back and talk a little bit more about the test, some of the updates that have happened, some things that are coming out of the laboratory, and just let everybody know what's going on in recurring UTIs and guidance UTI tests. So I'm thrilled to be here. Thank you.
Great. We're glad to have you back. So I'm going to bring up your slides and.
All right. Thank you. Well, again, I know, Vic, thanks so much for the this introduction today. I'm going to talk about recurring UTIs and looking at evidence-based testing. We're going to talk a little bit about some of the new data coming out of the laboratories, and we're also going to talk a little bit about what we're seeing for some of the national data on UTIs, as well as looking at some states. So we're going to start by just talking a little bit about recurring UTIs. I know many of you tuned in last year. There's a lot of people that are also using the Guidance UTI test for their recurring difficult to treat patients. And then I'm going to end with looking at some of the national and state data. So as clinicians, we're always looking at and meeting these patients that come back with these UTI infections, and they're symptomatic and very difficult to treat, high resistance. And so what do you do? So of course, as clinicians, we start with taking their clinical history, understanding a little bit about their background. And then once we understand a little bit about the background about the patient, then we have to sit and start deciding about our diagnostic method. What do we use? Well, of course, there's many different things. There's UA, urine analysis. There is standard urine culture with AST, with antibiotic sensitivity testing. Now we're also moving into molecular diagnostic methods, and Guidance UTI is a test that falls under, the molecular diagnostic test. It's a very unique test. We're going to talk about it a little bit today. And once you have that picture of the patient as well as using your diagnostic tool, then you can sit and decide now how you want to treat this patient. So to start off with, I wanted just to review for the audience about the Guidance UTI test. And this is a unique proprietary test that is made for that symptomatic, recurring, very difficult to treat UTI patient. And it's a two-part test. It uses midstream voided urine or catheterized urine or bladder wash. And so we'll take those three sample types and we will first run a PCR test where we're looking at a very small, clinically focused group of organisms that we know that are the ones that are the uropathogens that we see in the bladder. And so we'll look at do a PCR to identify that they're there, if they're there. So we have 26 organisms and 3 bacterial groups that we want to see if they're there. And then we'll also tell you the presence of any resistance genes that are there. And we look at 32 resistance genes. So that's the detection part of it. And that's that genotypic detection that we need to see what's there. And then next, we'll take that patient sample and we will run a pooled antibiotic susceptibility test where we take that sample with all the organisms together, and we want to have all the organisms together and run susceptibility testing, because we know that when these organisms are in the bladder, they can modify antibiotic resistance. They can communicate with each other, try to protect each other when antibiotics are given. So we do not want to look at them as isolates that standard urine culture does. We want to look at them all together. So that is a pooled antibiotic susceptibility test. And that's what makes the guidance test so special. And so here it's just a nice view of what we're capturing with looking at these organisms. And you see in this list that you're seeing gram-positive, you're seeing some gram-negatives, you're also seeing fastidious organisms, which are the ones that grow beautiful in the body, but when you send a specimen to the laboratory, it doesn't grow like to grow in a standard urine culture condition. It needs a lot of enhancements to grow, and even then, a lot of times it's very difficult to grow. So that's your ureaplasma, your mycoplasma, your Ericoccus. Those are some of the fastidious ones that are detected and identified in a guidance UTI test. And then, of course, you can see that we also have our susceptibility testing. We've just expanded it since last year. So since our last time I was visiting this show, we have expanded it now. So we have more PO formulations to run our susceptibility test. And of course, we have the 6 antibiotic drug classes identified in this test. So I love this slide. This is just a nice way to look at what would you get if you send us a sample. You can sit and see that's going to be your patient sample report. And so you can see all at the top, when you see the number 1, you can see the organisms that were detected out of this panel. You can see the semi-quantitative value. And then going across, you can see all the antibiotics at the top that are going to be run in a pooled antibiotic susceptibility. And then if you look at line 3, you can see the green S or the red R. We also report in intermediate for people that have a very high resistance in this infection. And this is really important because we're looking at the pool of organisms and figuring out what that susceptibility is. So by identifying the green S, it's covering the pool of the organisms that were in your patient sample. And I think that's very important. So what are some of the patients that you would use this test for? Well, symptomatic patients that, of course, have a reoccurring, persistent, or a complicated UTI. Patients that have some type of elevated risk, they're immunocompromised, or the elderly. Once maybe you have a patient that you don't know whether this is actually a UTI or whether it's interstitial cystitis. And you could figure out whether the presence of organisms, pathogenic organisms that are there or not. And so you could actually rule out IC with this test. And then also if you have a patient that has a lot of antibiotic allergies, hypersensitivities, it would be a great test to use just to give some choice on an antibiotic that would cover the organisms for a patient that may want to try to avoid certain antibiotics. And so this test, just talking about what diagnostic tools are out there just thinking about how they all compare. So we just reviewed the guidance test. It has 26 organisms and 3 bacterial groups. So it's a small targeted panel that we're looking just at the organisms that we know that are frequently identified with this reoccurring difficult to treat infections. There were 32 antibiotic resistance genes. And of course, it identifies polymicrobial infections that we want to see and capture the bacterial interactions that can modify that resistance. So we test them all together and susceptibility. And that's very different than PCR. We are not a PCR test. We have a PCR component. We have to tell you what's there. But after that, it's this beautiful susceptibility test. So PCR, it will vary among the amount of organisms. Some have more, some have less. So PCR is just what you want to detect. Resistance genes may or may not be included. Some do, some don't. And they do not run susceptibility tests. They essentially just look at what organism you detected and look in, a Sanford guide and match what that antibiotic's going to be to treat that organism. So there's no susceptibility testing that is given to PCR. That's patient specific. It's just literature specific. And standard urine culture. So standard urine culture is something that we've had for a really long time. We already talked that fastidious organisms do not want to grow in a standard urine culture so that you're not going to have that detection. And of course, standard urine culture can grow 1 organism, 2 organisms, but when you start getting into 3 organisms, it will come back as contaminated or multiflora. And that's very difficult for clinicians because you really are not really sure what you're dealing with. You have a contaminated sample, and you're just going to have to use empiric therapy and decide what you feel is going to be an appropriate antibiotic to treat this patient. There's no antibiotic resistance gene detection using a standard urine culture. And when you want to run a susceptibility and AST test with standard urine culture, what they'll do is they'll take that 1 organism or 2 organisms, separate them into 2 different dishes, 2 different agar plates, and then run susceptibility testing on each one individually. So you're really determining susceptibility in isolate compared to looking at them all together like they are in the bladder. So it does not address any of these pathogens when they are together. And so this is just a nice schematic. I thought I would show this is that you can see on the left-hand side that they will take a dish with that patient sample, and this is a standard urine culture, and they'll take an organism out, place it in a separate dish, and then determine susceptibility to each one in isolate. And on the right side, that is our pooled antibiotic susceptibility, and that's what guidance is that we're taking all the organisms, all the colonies, we're putting them together in a liquid media with that antibiotic and determining susceptibility that way, so that the antibiotic and all the organisms, all of them are all moving around. So you're capturing all of them together. And it's a more comprehensive view to look to see what these organisms are doing and more like what the environment in the bladder is in your patient. And so I thought this was a nice update from our laboratory, is that we just showed a picture of an agar plate where you have an organism that grows in these colonies. So this picture I thought was fun for us to show today is that you can see on the left-hand side, that is the master plate. And that we'll say that's E. coli growing, and you could see all the colonies. And you can see that the next plate over, in that agar, we added an antibiotic. So we added piperacillin tazobactam. And what we did was we took a piece, it's called replica plating in the laboratory. We took almost like a piece of velvet, and you stamp that master plate, and then you go to the next plate and stamp that plate. So essentially you're trying to make a replica of those organisms at the next plate. So you could see that we stamped the master plate, and then we stamped the piperacillin tazobactam plate. And lo and behold, you can see that each colony continued to grow and made an exact duplicate of the master plate. So we can say that those colonies were all resistant to piperacillin tazobactam. It kept growing. Now look, if we do this again and we stamp that master plate and we go to the next one, which was 2 over, that's nitrofurantoin. And when we stamp that, none of it grew. So we can say that that was 100% sensitive to nitrofurantoin, which is fantastic. And then the last plate I wanted to show you is we stamp that master plate and then stamp the Cipro plate. And lo and behold, look what we have here. As you can see that some of those colonies grew and some of them didn't. And so now we're starting to understand that in that master plate, that there is different resistance among all those colonies. So there's some sensitive and some resistant. And this is really significant because when you're doing a standard urine culture, I'm going to go to that master plate and I'm going to choose 3 of those colonies to transfer to another plate to run sensitivity. So out of those 3, which ones did I choose? And so this is now becoming something that we're talking an awful lot about in laboratory space, is heteroresistance trends that you see. And this is one that I wanted to show in specifically if you're talking about UTI is that it really will make a difference what colonies you choose to decide your susceptibility in a patient. And this is something that's really special about guidance is that we take all the colonies, all that one that are on the master plate, all of them, and we figure out a summation resistance based on all the colonies, not just picking and choosing a couple off the plate. And when you're dealing with heteroresistance, it becomes a much bigger talking point and a much more accurate view of susceptibility testing. And then this is another one that I thought was a really nice data to show everybody. And I can talk a little bit more about this later as well. But remember, we're talking about these organisms when they are in the bladder, that they communicate with each other and they try to help and modify their resistance. So what we're starting to see is that you're starting to see on the top line that you have sensitivity of E. coli just by itself. And that top line you can see. I know it's a little difficult to read this, but you can start to see that basic sensitivity when E. coli is by itself. And then you could see the next line down that E. coli, when it has other organisms by itself, that their resistance is increased a little bit. So E. coli, when it gets together with other organisms in the bladder, it increases its resistance a little bit. And then the final line it's when E. coli is together with E. faecalis, Enterococcus faecalis, in a polymicrobial infection. And I can nicely tell you that the resistance has doubled in that infection when E. faecalis joins in with E. coli. So it's really interesting. We're kind of scratching the surface on this, but it's really interesting to see how susceptibility, how resistance is modified when these organisms are by itself compared to other organisms such as E. faecalis. So to look at each one in isolate is not capturing any of this resistance that we're seeing, this modification in resistance. So I know a lot of you, we've already talked a little bit last year about it, and I'll share this with the audience later, but we have now, I think at present, since last time I came on the show, we have more publications. We've done a lot of research looking at UTI, looking at these organisms, looking at pooled antibiotic susceptibility, a lot of clinical trial data on standard urine culture compared to guidance, seeing a reduction of about 40% in hospitalization using guidance compared to standard urine culture. And it's really kind of a fascinating look. So I'm happy to share it. There's the QR code, but I'll share it later as well with the audience. So you can read any of our publications. We're up to about 25 right now, and more are coming this year. So I thought now I would go into talking a little bit about some of the different data now that we're seeing nationally. So if we're seeing national data, we're going to go ahead and see that E. coli is, again, the most frequently detected organism in UTI patients, but it's followed by Enterococcus faecalis, and then Actinidium shallei, which is a fastidious organism, so that, again, you would not detect that in a standard urine culture. Viridans group strep, Aerococcus urinae, which is another fastidious organism, Gardnerella vaginalis, another fastidious organism. So you start to see going down gram positive, gram negative, but you also see a lot of fastidious organisms in the top 10. You can see Streptococcus agdalacti, Proteus mirabilis. We also include Candida, so you can see some Candida glabrata, and you see some ureaplasma, mycoplasma. And so it's interesting to look at some of what we're seeing nationally with our detection. And then the other thing that we do with our guidance tests, which we talked about, is we'll also detect if there's resistance genes there. We wanted to identify that. So what do we see with resistance genes? We see a lot of ESBL resistance genes, so extended spectrum beta-lactam resistance genes, which are the penicillins. We see a lot of methicillin resistance genes, ampicillin. You can see fluoroquinolone, quinolone, vancomycin. At the bottom is carbapenem. Great that we're not seeing a whole lot of carbapenem resistance genes, so that keeps it quite small. And this is just a look at that the genes are there. Doesn't mean that they're being expressed. It doesn't mean that it's turned on. It's just there. And so that's that genotypic information. Is the DNA there? So yes, you can see this is the DNA of the resistance gene that's present. So that's that genotypic information. So nationally, what are we seeing with susceptibility? So looking at just these symptomatic UTI patients, we're seeing the highest susceptibility is piperacillin tazobactam. It's an IV drug. We know it's one of the one that has great susceptibility, but it is IV. It's really ones for very highly resistant infections. Phosphomycin is number 2. We see, again, a very high susceptibility and nationally with using phosphomycin. Nitrofurantoin is number 3, ampicillin, sulbactam, meropenem, amoxicillin clavulanate, cefepime, and you could see going down. And I think this is really interesting when I go out and I do a lot of presentations. I always try to ask my audience kind of where their empiric therapy kind of falls among this, because sometimes you guess right and you think, oh, okay, well, I love phosphomycin. This is something I want to give to my to my patients. But then there are also some people that will look and say, oh my goodness, ampicillin. Well, ampicillin's all the way down at the bottom. So it's really a fascinating look to kind of see what you're doing, and then also kind of seeing at national trends for UTI using this polymicrobial way of pooled antibiotic susceptibility testing. And then lastly, we also want to look at what are some of the differences you expect with genotypic information, deciding whether the antibiotic resistance gene is there or not there, versus phenotypic expression. And that is that pooled antibiotic susceptibility. What does the organism do when it's in the presence of this antibiotic? So looking at this, you can look at meropenem, and you could see this meropenem line right there. And you see this blue line, and the blue line is what you would predict if you just looked at genotypic information, which is just PCR, just identifying, is the resistance gene there or not there? So you would think, because remember we said there's very little carbapenem resistance genes, I would predict, because the genes really aren't there, that it would be close to 100% sensitive. But if you use a pooled antibiotic susceptibility where you're testing all these organisms together with that antibiotic, what did these organisms do in the presence of meropenem? You can actually see the susceptibility is much lower. It's closer more to 50%. And that discordance between, that difference between what you're seeing with a predicted view of the genes there or the genes not there, the resistance gene, versus what it actually does when you place these organisms in the presence of an antibiotic is very different. And that discordance you're seeing quite high. You can see Cipro has very big discordance. You can see vancomycin has very big discordance. And it's really fascinating to kind of look at this difference between genotypic information, which is just looking at, is the resistance gene there or not, versus phenotypic expression of what actually you see with susceptibility when you place these organisms in the presence of an antibiotic. And so I think that's really eye-opening to look at that nationally. And then just, I don't know all the audience members, so I just pulled some data from some states just to kind of show you some of the little differences that we're starting to see. Is just look at California versus New York and organism detection. Okay, you still have E. coli for both of them, so that's the number one organism that was detected. But when you start getting down to number two, look, E. faecalis is the second detected organism in California, next to Ericoccus urinae. Completely different in New York. You have Gardnerella vaginalis is number 2, Viridans group strep, and E. faecalis is number 4. A. shallei is number 5, which is again a fastidious organism. So you could see the organisms vary very much significantly between state to state. So depending on your state, you're seeing different microbial detection in these different states. So I thought that was kind of interesting, and let's look at another one. So I thought maybe looking at Arizona and Massachusetts would be nice. 2 different states, 2 different parts of the United States. Again, you see E. coli is number 1, and then you see E. faecalis is number 2, Ericoccus urinae is number 3. You can see Actinidium shallei, which is a fastidious organism that is highly associated with negative patient outcomes. So that is number 5 in detection in Arizona. But in Massachusetts, look at it, it's number 2 in its detection, even above E. faecalis. And so again, different parts of the United States show different organism detection. And I just chose a handful to show you today. And then same thing, I just pulled those states again and wanted to look at susceptibility, at looking at pooled antibiotic susceptibility for patients that live in those states. So what would be a difference that you should start to see here in California versus New York? I just decided to pull here. You could see gentamicin, and gentamicin is definitely a top 5 in susceptibility here in California, but it really starts to fall in New York. And so it just doesn't have that higher susceptibility for patients in New York. And so you're seeing some of that variability from state to state. And then again, looking at Arizona and Massachusetts, you can sit and see here, you can see Cipro is down here more toward the bottom 10 in Arizona, and it doesn't even make top 10 in Massachusetts. So again, lots of variability that you're starting to see from state to state in organism detection, pooled antibiotic susceptibility for your patients. So it's really fascinating to sit and to start to look at some of these national trends, starting to see that variability from state to state. So it's very important to start to customize what you're detecting and also what you're using for your susceptibility testing to really treat your patients effectively. And that's what makes the guidance test so special. And so for us, we've talked about the guidance test. This is something that we offer is that we offer a guidance UTI practice review. And what we do is we pull all your guidance UTI data into all these different components that we all just talked about, the organism detection, the antibiotic resistance genes, that pooled antibiotic susceptibility results for your patients. So we pull all this data and we present all this data to you to personalize what you're seeing and how you're treating your patients. And it's really great. So instead of looking at national trends, you're really going to look just at your patient data and using that to get a snapshot of what you're seeing in your practice. And it really is just that precision medicine, bringing that precision medicine and that diagnostic to your practice. And again, the pieces that I presented today are all things that are going to come to you for your patients. It is that organism detection, so that you're including gram-positive, gram-negative, but also those fastidious organisms and yeasts that are not going to be detected in standard urine culture. You're going to have identification if there's an antibiotic resistance gene that's present that you want to see that. You'll also see that we'll give you a pooled antibiotic susceptibility result for your patients. So you can see just what I presented today, just for your practice. And also, we'll also calculate and present that discordance data between genotypic information versus phenotypic expression. And so you'll really get this precision tool for your patients and for your practice. We do this, and then we'll keep coming back every 6 months and keep doing all the updates for you so that you can sit and follow any changes that you need for your UTI patients. And we're, since last year, I always like to say we're growing by leaps and bounds. We have a lot of providers all throughout the United States. This was a snapshot of where we were in the last couple months. This continues to keep growing, and we just love being out there. We love presenting. We're at most conferences, and we love just to kind of show this test and talk about its uniqueness and how it really helps and benefits and improves patient outcomes in these reoccurring, very difficult to treat patients. Thank you. And I know we'll open it to questions here with Vic. I will have all these information to share also at the end of the presentation today.
Yeah, that was really great. For audience that's watching live, if you have any questions, go ahead and put them into the comment box. We'll bring those up. I'm going to kick it off. So I kind of like the nuts and bolts approach. So maybe you could walk us through from, collection of urine sample to what you guys do when you receive it and how all these tests are then falling in.
Yeah. So it is midstream voided urine or catheterized urine. So, everybody has what they feel more comfortable with. So we'll accept it both. We've also are going to accept bladder wash. So you're just going to collect it. We have two tubes that we collect. We give you a little kit. So you just transfer your urine into these two. It's a gray top and a yellow top. And you put it into a box, and it's a FedEx bag. And it just ships overnight through FedEx to hit our laboratory the next day. And then we say within 24 hours upon receipt to the laboratory, you get the organism detected, you get the susceptibility testing, everything. And so it's very nice. It's very fast. So remember, you don't have to grow anything. You don't have to do a standard urine culture where it takes, 2, 3, 4 days to get that result, sometimes even longer. And it makes a big difference when you're making a decision with your patients.
What is the
We offer
turnover
that
time?
in-home
Yeah, what
24
is
hours upon
24 hours?
receipt.
Yeah.
And then we also offer home kits. And we started doing that years ago during COVID, and it really took off. And so if you have a patient that you can't see in the office, or they can't get to the office, or they live hours away from your office and they just can't get them, you can't do the trip in, you can fill out a requisition form and tick a home kit, and we will overnight a box to them. It comes overnight to their house, and they do a midstream voided sample into a little cup, and they screw the top on, and we will arrange for FedEx to come pick it up from their house. They don't have to go anywhere. We'll just come to them, pick it up. We'll FedEx it back overnight to the lab, and then you'll get that result without them having to come into the office. So that's another option that's out there that's really popular for a lot of the audience for lots of different reasons. So,
yep. I'm going to bring up a few here. Diane, welcome from Seattle, and Fran from Massachusetts, and Charlene from Springfield. So we've got a nice group of people from around the country watching the show live, and a bunch that didn't tell me where they're from. So we'll just guess that they're somewhere in the country. We were talking earlier, and I was saying that we had those that watched the show on a regular basis know we had Todd Thompson on, who's the real expert, calls himself the self-proclaimed guru of chronic catheter problems. And so we had talked about that. We send in a catheterized sample, and we'll get it back from the typical lab saying contamination, and they won't, because there's 3 or more organisms, so they don't run it. And as you and I were talking about earlier, your company's going to run that, and it's going to give the identifications.
Right. Exactly. And that really makes a difference, because as a clinician, you really need to know what's in this polymicrobial UTI. And we're seeing that in this symptomatic, reoccurring, difficult to treat patient, that we're seeing polymicrobial infections in 52% of the times. So when you start getting into these infections, you're seeing a lot of polymicrobial infections. So if you're using standard urine culture, which that is the limitation of standard urine culture, is it can grow 1 organism to 2 organisms. And when you start getting to 3, what happens is they all start growing on top of each other and kind of crowding each other out. And then in the laboratory, remember we showed that picture where you have all those colonies, they all grow together. And so you can't identify and to further identify and determine susceptibility. So that really is kind of the stop to standard urine culture. Is 1 or 2 you can probably do, but after that you can't. And so for us, we want to just identify a very small subset of what organisms are out there in the human body, that once they get in the bladder, those are the ones that are more frequently identified as the pathogenic organisms in the bladder. So we're not looking at all of them. We're looking at just a very small subset. So thank you. And that's it. You can actually start to see.
I wanted to bring that slide up, because that's kind of interesting. And I hadn't really thought about that before, is when you test the typical urine, they're just culturing what they kind of identify. I used to do these, years ago myself, and you would pick the organisms out, plate them out, and see what, the antibiotic disc showed.
Right.
But we weren't plating them all as one big thing and treating it, which is kind of a neat approach.
No, it's really interesting. And I thought this was a really interesting slide to sit and start talking to the audience about what we're seeing with heteroresistance. And, when you're talking about infection, and today we're just talking about UTIs, but this is what we're seeing in laboratories. You're seeing a lot of heteroresistance within a population. So like this one, we said E. coli, and you see all the colonies that are on that agar plate. And each one of them is its own little colony of E. coli that came from a patient. So when you're determining susceptibility, you're going to choose your 3 colonies, you're going to transfer it to another one, and then you're going to figure out that susceptibility. But if you start to identify that there is heteroresistance within an organism with all these different colonies, then all of a sudden it's which one did you choose to decide to run your susceptibility? And when you see heteroresistance, it becomes a bigger deal of what you're dealing, which one you chose to figure out that susceptibility. And this is just, looking at this is just one organism. And you could see the big difference between looking at those plates. And when you see the Cipro plate, then all of a sudden it's like, oh my goodness, well, which one did I choose from the beginning? Because then now you understand that there was a lot of heteroresistance in those colonies to Cipro. So I may not be calling that susceptibility correctly with Cipro just because of the heteroresistance within that population. It's really fascinating.
Treating them with the wrong antibiotic is what helps to initiate all this resistance that we see now.
Yeah, and it's difficult because remember, a lot of times I speak to a lot of providers and they'll see that there's a polymicrobial infection and they'll say, well, okay, I think I just want to treat this one here, this one organism here, and there's two other ones there. And really, it's the clinical discretion, that you decide that you want to sit and to do that. But understanding that you may want to treat one and you may not want to treat the others, that you could possibly see that the others continue to keep growing, whereas you may be treating one and you're also exposing the other two to an antibiotic that may not treat them. And then all of a sudden you're growing some and you're growing them resistant and you're only treating that one. So yeah, it's something to really think about when you're talking about a polymicrobial infection and how you do that. And that's what makes this test so special is it's looking at a polymicrobial infection and figuring out that susceptibility, not one colony, not two colonies, all the colonies, and looking at that bacterial interaction like what we saw in the presentation between E. faecalis and E. coli. And you start to see that there's some resistance that you see in E. coli, but once you start adding in other organisms like E. faecalis, you double the amount of resistance just by them being together. And again, they're trying to protect each other in the presence of an antibiotic. And so it's that bacterial interaction that is so vital that you also take into account when you're trying to figure out that susceptibility. So,
and clinically, what we see is, the patient comes in, we treat them based on the culture result, and they come back and they're no better. I still have an infection, and you're like, half of us start thinking, maybe they're just crazy. Some people, we know, they just want to take an antibiotic constantly, thinking they're going to prevent an infection. But really, it's just that it was improperly treated. That's I think what we didn't know.
Yeah, one publication that we did actually since our show last year was looking at symptomatic patients and looking at symptomatic patients that were standard urine culture negative. So we took a group of patients and we saw that standard urine culture and guidance, sometimes you would have standard urine culture negative patients, but you would have a guidance positive patient. And so all of a sudden you're looking at that. And what we did was we also identified 3 biomarkers of active UTI, which we can identify in a patient urine. It's made by the urothelium of the bladder. They're inflammatory cytokines. And so that they're made when these organisms are in the bladder and it's an inflammatory response. So in that patient group that was standard urine culture negative but guidance positive, what we did was we decided to look at these active UTI biomarkers. And lo and behold, we saw all this elevation of this inflammation in these patients, so that we understand that a lot of standard urine culture negative patients that are symptomatic truly do have a UTI. Their body is making inflammation against these organisms in the bladder. It's just that standard urine culture, it has limitations. So you're not capturing that. And that's, so when you see a patient that's symptomatic and you do a standard urine culture, you may not be capturing everything that you need to see to treat this patient effectively. And that's why you have guidance that comes forward and we know what these limitations are with that sensitivity, picking up the fastidious organisms, the gram positive, gram negative, the turnaround time that you can do it within 24 hours, and then also not being limited by a contaminated, result. You're not going to get a contaminated. We'll let you know what's there, what's clinically relevant to identify for you in these patients. So it's fascinating when you start to see, and knowledge is changing, everybody. That's the other thing, is where we were even 5 years ago is completely different to where we are right now. And so we're looking at the urinary microbiome. We're looking at all this very delicate relationship between organisms that are very happily living in the bladder, but then you start to see a dysbiosis occur, and some of the protective ones start going down, and the ones that weren't causing any symptoms before all of a sudden start overgrowing and start becoming pathogenic. And it's really fascinating, and that keeps changing, and more information's coming out on that.
Yeah. So well, years ago, we used to think that the bladder should be sterile. There should be no organisms in it. And we know, as you mentioned, the microbiome we're full of bacteria. It's normal. It belongs there. It is protective reasoning. So you don't want to treat everything.
No, and you don't want to treat everything. And that's what makes this so special, is because you don't want to treat everything. You just want to treat the pathogenic ones in that symptomatic patient. You don't want to touch the other ones that are out there, because you start developing that dysbiosis, and then all of a sudden it just gets worse and worse, and they get into a very bad cycle and start getting overgrowth and colonization, and that's what happens, unfortunately.
And that's really been the key change in the way we treat now. Is it's not just treating the organism, we're treating the symptomatic patient. And that's what we really wanted to focus on. And I tell you, one of the things I noticed with your test, because we've had patients that they've gone to multiple urologists, multiple family doctors, and they're gotten better. And so then you suddenly do the test and you're like, well, you actually had something going on here. It was missed. You treat them, and now they're not symptomatic. They think you're a genius, so nothing wrong with that.
What? No. Well, again, we've done a lot of publications where we're specifically looking at improving patient outcomes. I love to talk about the science, because that's my background. I've been in laboratory for my whole life, and really specialize in molecular diagnostics. But with all that knowledge, you have to make sure that you're making these patients better, that you're not having them go to hospital or doing urgent care or utilizing antibiotic therapy. And so we're trying to limit all that as much as possible. And so we did publish an article about a year and a half ago through one of the journals with the AUA, where we actually saw that reduction in utilization of hospitalization and reduction in antibiotic therapy in the group that is using guidance. And it's a significant thing. We really want to make sure that we are making people get better and not ending up going to hospital and not being treated, empirically. It's that precision tool that we're trying to bring to these patients. And so
absolutely.
Yeah.
One of the last things I wanted to kind of mention or have you discuss for us is cost. What's the cost compared to a typical routine culture? Is it covered by insurance? Is it not? What Medicare is, now that I'm a Medicare recipient? Those are questions that I like to ask. So what are the cost and coverage?
Yeah, we work in network with a lot of payers, which is really wonderful. And so our test gets covered very nicely by payers. We have zero Medicare cost, zero Medicaid cost, which is great. You just want to make sure that the people that need to test can test, that they don't have to worry about getting a big bill. The other thing is if there is a copay or something that is very high, what the patient needs to do is we have like a little sheet that's in every kit. If you're a provider out there, we have like a little tear sheet that we can give to you so that when you order the test, you just hand it to them. If there's anything that is a higher bill or something that they really have a difficult time with, we can reduce that cost by them just calling us to an in-network price, and it's about $50, and that's nice.
Wow.
And it's actually, most of the times I'm seeing it much less than $50. I've seen it as low as $4 or $5 for a lot of patients. It just really depends on your insurance. But we have that Pathnostics Promise program, which we can reduce it to an in-network price for you.
Yeah.
So Medicare,
a lot of patients probably are not aware of, that you could just make a phone call sometimes.
yes,
you get a crazy bill, talk to the company. They can do something for you many times.
Yes. And so, and I think it's really important because you want to make sure that it's already a scary time. You don't feel well. You're going to the doctor. You're trying to help, get help. And the last thing you want to do is to start seeing a bill. And, and so
you tend to get the bill once you're cured. And at that point, when you're symptomatic, you'll pay anything. But once you're feeling okay, it's like, what do you mean it costs?
I know. And so, and then of course, we have to do an EOB. So for anybody, that is a compliant thing that we have to do, is that your patient may get an EOB, but that's not the bill. That's just an estimate of what it's going to be. And so just please remember the Pathnostic Promise. It has that little card in every kit. It has a telephone number. Just call us. We will take care of it for you. And it's really what we want to do, and try to move it forward to the rest of the people that really need to be able to use this test. So,
Margot, has been a great talk. I see a lot of people are watching it live. So for all you out there, I guess I must have been answering all the questions that you were thinking of, because nobody put any questions in. But it was really great. I'm going to put a clip in for next week's show.
Inside the OR. What a nurse anesthetist actually does. Patrick McElhone, Chief CRNA at Hines VA, offers an authentic, behind-the-scenes look at the critical role nurse anesthetists play in the operating room. Drawing from his extensive experience, Patrick walks viewers through the pre-op assessment, induction of anesthesia, patient monitoring during surgery, and the crucial handoff during recovery. With a calm and confident presence, he highlights the clinical expertise, rapid decision-making, and compassionate care that define the CRNA profession. This video is an eye-opener for aspiring CRNAs and a powerful reminder of the expertise that drives safe, patient-centered care every day in the OR. Join us May 17th to learn more at yourownurse.com.
Yeah, so join us next week. I heard Patrick speak recently about becoming a CNRA and what they do, and I thought it'd be great to bring up, especially during Nurses Week, because anesthesia is often thought of as something that's the doctors are involved in. It started with nurses, so it's kind of interesting to get that nursing perspective from it. But hey, it's been a great pleasure having you on the show, Margot. We hope to bring you in again to keep us up to date with what's going on. But this was really a nice catch up on what's new and exciting.
Thank you. And remember, we're at most conferences. We've got some presentations coming up. Our next one is with the American Society for Microbiology, Microbe. So we'll be there next month with symposium. So please reach out to us anytime. We'd love to have discussions with you and talk to you more about the test, answer your questions, I'll leave some resources also here with the UroNurse program. So if you'd like to read more about it, contact the show, and we'll share some more information.
All right, and we'll see everybody next week on your